Good day, y'all. My name is Amechi Ofune, the new coding educator for neurology, auto and spine, rehab, and psych. I just want to use this medium to appreciate my predecessor, Pat and Lisa, for the good work. And also want to introduce myself coming into this very new, just about 1 week or so in coding education department. The first thing I just want to do is to appreciate some of you have gone through some of the neuro cases, and I want to appreciate you for good work on your documentation, but we need some little improvement which is going to come with this presentation. It is all about the new changes in ICD10. Just a little bit of background on what we're supposed to be getting here today. We have a number of codes coming in to neuro, about 270 something changes. These are new, and we have about 110 of revised and deleted codes, which share about 50% each. And you can know that the reason for this great number of codes coming in and then being deleted is because in 2011, when America was supposed to start with ICD-10, remember we had to move it over again to 2012, again up to 2015 when it was implemented. Through 2011 to 2016, there has been a code freeze. This is the first time code is being added to ICD-10 since 2011. That is why you have a number of codes being new and then some deleted and some revised. So that is a brief history of why we are dealing with new codes. Now, the good thing is there's a lot of clarity coming into ICD-10, and I want everyone to just stay with me as we go through it. Number one aspect of this is unspecified diagnosis. If you look at it, 2016, we are going to lose the grace period of a Medicare, though we have also been able to learn from Medicaid about these unspecified codes. I want to stay here and let you know that all procedures with unspecified codes will be rejected by Medicare. Basically not all, but some of them will be rejected because we know there are few instances where you cannot but just still have to put an unspecified code. So, but we want it to be minimized by getting a specific code. Now, practices submitting unspecified ICD-10 code after October 4, 2000 may potentially experience an increase in claim rejection. Documentation tips. You try and update your problem list of most current specific diagnoses. Also, remove duplicate or conflicting diagnoses. Document according to acuity and specificity. Some documentation require identification of organisms for proper coding since it may be captured as primary diagnosis. An example is sepsis. Document cause and effect relationship as well as associated chronic conditions. Probable, suspected, and consistent with conditions should be documented as assessed with associated signs and symptoms, but if possible, avoid for effective professional billing. Post-procedural complications. We are now going to talk about complications, which is a very large area of this year additions. And so we're going to talk about it. It shares almost 50% of the addition this year. So we are going to be very, very attentive on issues of complication. Post-procedural complications are highlights of 2017 ICD10 code changes because it is about 50% of the addition. Documentation, therefore, will require identification of related procedures, device implants, stroke systems, and grafts, etc. Specify the type of complication, mechanical, infective, adverse effect of drugs. It is important to know that all conditions relating to follow-ups and return to OR require great clarity for appropriate modifier use to avoid losses to provider effort as well as denials. This helps effective coding. Another highlight is breakdown, which is mechanical, of implanted electronic neurostimulator generators, system devices, implant or graft. Please specify site of breakdown, e.g. cranial nerve, gastric, sacral, or vagal. New codes for neurology. These are the new codes, but these are not all that you eventually see, because right now we're talking about 2,651 new codes, new changes, which about 1,943 are new. But in neurology, we are seeing some new codes. They are all there. Like I said, it's about 370 new codes. So I am going to just specify very few and the things that, those ones that you will lay emphasis on. Lesions of limbs have now been expanded with specifics, hence a need for identification of laterality in documentation. Carpal tunnel syndrome now has bilateral upper limbs. Bilateral has been added as a code choice for calcialgia and myalgia. Cerebral infarction has been further redefined with references to its cause. You look at it, you will see bilateral has been added as a code choice for cerebral infarct diagnosis. Previously, unilateral, left, right, and left, codes were available. Please indicate cause as any of these: thrombosis, embolism, and stenosis. Specify artery, carotid, vertebra, middle cerebral, anterior, posterior cerebral. Post-procedural complication following nervous system, organs or structure, system or prosthetic device, implant or graft procedures have a fair share of the code changes. Examples are neurology system device implant or graft, neurology system prosthetic device, ventricular intracranial, that's communicating shunts, implanted electronic neurostimulators, cranial or spinal infusion catheter. These were expanded to cover the following complications: indication of hemorrhage, hematoma, or seroma, indication of leakages, indication of infection and inflammatory reactions, embolism, fibrosis, and stenosis, mechanical displacements or breakdowns, pain due to specific complication, non-traumatic subarachnoid and intracranial hemorrhage has been expanded to include codes deficits. NIHSS codes are completely new additions. It is a complete check of status of stroke condition. This is now required in any documentation of such for an effective and efficient billing and reimbursement. We now have 43 additions for this by score breakdowns. Glasgow Coma scales have been redefined. All 3 existing codes for Glasgow Coma scale scores were deleted and replaced with 20 new redefined codes created in specific terms of time, stroke location. This means that documentation will now require an indicator of where or time of initial active phase. Unintended awareness under general anesthesia during procedure is new addition. Also, observation and evaluation of newborn for suspected neurological condition ruled out is now a new code added in 2017. Note this is about the revised description. Also, I'll be talking about deletions here. Like I said, we have about 110 revised and deleted codes. Those deleted codes are just codes that were existing but have to conflict with the new codes. Now, the revised codes were just a mere tweak of the language. Like you can see, a good number of neurologic-related complications in 2016 were reversed. They were all a switch of the words for clarity of condition. In the past, it is complication of, now it is complication due to. Some attention will be needed in nerve injuries as some of its unspecified codes were reversed. As stated above, with complication code revision, type of complication, embolism, fibrosis, hemorrhage, stenosis, or thrombosis will help with accurate coding. In an indication of encounter status as initial active treatment, subsequent care, or involving sequela will be highly appreciated. Thank you. You can see that's my name, Amechi Ofune, and I am the coding educator for Autospine, Neurology, Psychiatry. If you have any question, please, you can get me on that number, 404-778-3947. Thank you.